Welcome to the deep dive. Today, we are tackling, well, a really tough and important clinical challenge, traumatic brain injury, or TBI. And our mission for this deep dive is simple. We're digging into a key clinical study. It's all about helping doctors get much, much better at predicting outcomes, the prognosis for patients with moderate to severe TBI.
Yeah, and that prediction, it's just so critical. TBI is unfortunately a huge driver of death and long-term disability everywhere.
Mhm.
When a patient comes in, that window to decide on the right tailored interventions is incredibly small. Getting a fast, accurate prognosis, that can change everything for them.
Okay, let's get into the specifics of this study then. They looked at 122 patients, right? All with moderate to severe TBI, which means their Glasgow Coma Scale scores, the GCS, were between 3 and 12 when they came in.
Exactly. And they followed these patients for 6 months after discharge.
Yeah.
They used what's called the Glasgow Outcome Score, the GOS, to gauge recovery.
Hmm.
And it's really important to understand this GOS scale. It ranges from 1 to 5. 1 is death, 2 is a vegetative state, 3 is severe disability. Now, that whole range, 1 to 3, the study called that an unfavorable prognosis.
Right. And then GOS 4 is moderate disability, so independent but still disabled. And GOS 5 is good recovery. That's the favorable group. So we're really talking about the difference between maybe dying or being comatose versus, well, having a functional life 6 months down the line. Huge stakes.
Absolutely huge. And understanding why prediction is so tricky means looking beyond just the initial hit. TBI, you see, it happens in 2 phases. Phase 1 is the primary injury. That's the mechanical damage, the force itself, like think of a wave crashing onto the shore, that immediate impact.
But that's not the whole story, is it? I gather the real problem for predicting how someone does long term comes later.
Precisely. The secondary phase. That's the silent danger. If the first hit is the wave crash, this is like the tide that comes in afterwards and just keeps eroding everything for days, even weeks. It's all biochemical. You've got this cascade of inflammation, oxidative stress, apoptosis that's programmed cell death.
And why is inflammation so central here?
Well, neuroinflammation is really the engine driving that secondary damage in the central nervous system after TBI. It leads to leaky blood vessels, swelling, bleeds, lack of oxygen, all things that have devastating long-term effects on quality of life.
Okay, so if this secondary microscopic mess is what really dictates the outcome, why aren't our usual tools, CT scans, neurological exams, good enough?
Because they're looking at the big picture, the structural damage, a skull fracture, a large bleed, that's macro level. But the secondary damage, that's happening at the cellular level. It's chemical signals gone wrong. You need something dynamic, something that tracks those microscopic changes in real time. And that's where biomarkers come in.
Right. Which brings us neatly to the 2 key biomarkers this study focused on, interleukin-6, or IL-6, and procalcitonin, PCT. Let's start with IL-6. What's its role in TBI?
IL-6 is a really important cytokine, a signaling molecule. It's got many roles, but it's a major player in inflammation. After a TBI, it's produced heavily by activated glial cells. Those are the brain's own immune cells, microglia, astrocytes, right at the injury site. High levels basically signal intense inflammation and system-wide stress. We already use it as a marker for other things like heart problems, for instance.
Okay, makes sense. And then PCT. I usually think of that hormone in the context of infections, like bacterial infection.
That's its main claim to fame, yes. PCT is a precursor hormone, a small protein. Normally, you have very little of it. But during a serious bacterial infection, PCT levels shoot way up. It's quite specific for that kind of bacterial attack on the system.
So why is it relevant here in brain trauma where maybe there isn't a confirmed infection, at least not right away?
That's where it gets interesting. It shows how TBI affects the whole body. It's complicated, but a few things happen. First, the trauma itself can trigger what's called serous systemic inflammatory response syndrome, just a massive body-wide inflammation. Second, the brain injury can damage the blood-brain barrier. Think of it like a security fence around the brain. TBI can punch holes in it. And that allows things like PCT, which might be elevated within the CNS due to local stress, to leak out into the general bloodstream where we can measure it. So PCT can rise significantly even without a classic infection, just because the whole system is in crisis mode due to the TBI.
Okay, now here's where the study's findings get really striking. They compared the outcomes, the 72 patients who did well versus the 50 who had unfavorable outcomes, GOS 1 to 3. And the difference in their initial blood tests was, well, it was stark.
It really was a huge difference. Take IL-6, patients who ended up with a poor prognosis. Their median IL-6 on admission was around 600 picograms per milliliter. Now compare that to the good prognosis group. Their median was way down, around 100 pgml.
Wow, 6 times higher inflammatory signal right from the get-go. What does that tell a doctor at the bedside?
It tells them that secondary cascade, that inflammatory storm, is already raging. It's a massive red flag. It screams high risk, potentially much higher than maybe the initial GCS score or scan might suggest on its own. The cellular damage is already intense.
And PCT showed a similar pattern.
Yep. Poor prognosis group had a median PCT around 4 nanograms per milliliter. Good prognosis group. Much lower, near zero point 0.5 ngml. Again, a big gap indicating severe systemic stress right away. But here's the crucial part. The researchers did a more complex analysis, multivariate analysis, to see which factors independently predicted the outcome at 6 months. It wasn't just IL-6 and PCT. No, they found 6 factors that each had independent predictive power. These were hemoglobin, that's HEB, albumin ALB, then IL-6, PCT, the initial Glasgow Coma Scale score, GCS, and creatinine CR. So it's a mix, you see. Neurological status from the GCS, the inflammatory markers we talked about, but also these other general physiological markers. Oh, and older age was also linked to poor outcomes, but those 6 were the key independent ones.
That's so interesting because creatinine, you usually link that with kidneys, right? And hemoglobin with oxygen in the blood. These aren't brain-specific things.
Exactly. It highlights how interconnected everything is.
So let's talk about the predictive power then. Individually, IL-6 and PCT were decent predictors, right? Area under the curve, AUC around zero point 0.7.
Yeah, about 0.71 for IL-6, 0.79 for PCT, which is, okay. And AUC tells you how well a test distinguishes between 2 groups here, good versus poor outcome. 0.5 is useless, like a coin flip. 1.0 is perfect prediction. So 0.7 is, well, it's useful, but maybe not reliable enough on its own for really critical decisions.
But the real breakthrough came when they combined these factors.
That's the key takeaway. The composite model, the one that included all 6 independent factors, HB, ALB, IO6, PCT, GCS, and CR, that model showed superior predictive ability. The AUC jumped dramatically. It went up to 0.9173.
0.9173. Okay, translate that for us. What does that leap mean practically?
It means you're moving from a pretty good guess to something much closer to certainty. An AUC over 0.9 is considered excellent discrimination. For a clinician, it means if a patient flags high risk on this combined model, there's a very, very high probability they're heading towards that unfavorable outcome, severe disability or death, within 6 months. That level of confidence, well, it changes everything. It allows for much more accurate risk stratification right at the start. It helps decide who needs the most aggressive monitoring, maybe justifies riskier interventions you wouldn't try otherwise. It supports taking immediate, decisive action.
Before we wrap up with limitations, I want to go back to PCT for a second because there was a weird quirk, right? The relationship wasn't just more PCT equals worse outcome. There was an inflection point.
Yes, that was a really interesting nuance. Shows how complex these biological responses are. They found this inflection point for PCT at around 5 nanograms per milliliter. What they saw was, below 5 ngml, as PCT levels went up, the GOS score indicating recovery went down significantly. That's what you expect, right? More inflammation marker, worse outcome.
Okay, that makes sense. But what happened above 5 ngml?
That's where it got weird. Once PCT crossed that 5 ngml threshold, the negative impact of further increases seemed to level off, or maybe even slightly reverse, though it was mostly flat.
Why would that be? Why wouldn't even more PCT mean an even worse prognosis?
Well, the thinking is that by the time PCT hits 5 ngml, the system might already be in a state of maximal stress or damage related to that particular pathway. The patient is already critically ill. The secondary injury cascade is likely overwhelming things. So adding even more PCT doesn't substantially worsen the already very poor prognosis linked to being at that 5 ngml level. The ceiling of badness has kind of been reached for what PCT reflects. For doctors, it suggests that hitting 5 ngml is maybe a critical threshold. It signals the need for the absolute highest level of, well, clinical vigilance and active, aggressive intervention. It tells you the patient is right at that crisis point.
Okay, so pulling it all together. This deep dive shows IL-6 and PCT are definitely valuable prognostic markers in TBI. Easy to measure too. But their real predictive magic happens when you don't look at them in isolation, but combine them into a model with other key factors. The GCS score, yes, but also hemoglobin, albumin, and creatinine. That systemic view is crucial.
Exactly. Now, we do need to mention the study's limitations, of course. It was retrospective, looking back at data, not forward. That's generally seen as less strong than a prospective study designed from the start. And it was done at just one center, so, how well these exact findings apply to different hospitals or patient populations, that needs more research. Generalizability is a question.
And you mentioned the outcome measure, the GOS score, was mostly done by phone calls at 6 months.
Right, telephone follow-up. While they likely used a structured approach, it's just not quite the same as an objective in-person exam. So there could be some slight wiggle room, maybe some bias in how outcomes were classified.
Still, even with those caveats, that jump in predictive power to an AUC near 0.92 with the combined model is, well, pretty hard to ignore.
Definitely significant, yes.
So I think the really big lesson here is just how tightly linked brain injury is to the entire body's response. This work shows factors we might normally associate with other organs. Kidneys for creatinine, blood health for hemoglobin are actually independent predictors of how the brain recovers after trauma. They're not just side issues, they reflect the severity of that damaging secondary cascade. Which leads us to the final thought for you, the listener, to chew on. If TBI triggers this massive body-wide inflammatory response reflected in markers like CR, HB, and ALB, what if future treatments focus less only on the injured brain tissue itself and more on managing this systemic turmoil? Could actively controlling things like creatinine levels or boosting albumin actually dampen the whole body's inflammatory reaction and, in turn, improve neurological outcomes? The brain isn't an island, so we've given you the knowledge from this deep dive. Now go explore that connection.